everyone. We are going into beginning to take control of your pain. We are starting to work through the chronic pain portion of this class. The book you do not have. It was not required for you to purchase, so everything that you have or need will be in these PowerPoints or slides or from what I'm saying in my lectures. So this book talks a lot about, it actually is the author talking more to the patient themselves and not to students. So it is, I don't want to say dumbed down, but it is talked a little bit different than what you've seen in some of your other chapters. So this lecture here today is chapter 1 and chapter 2 combined from this book. So the objectives is know the 3 keys to taking control of your pain, understand the goal setting criteria, discuss types of nerve fibers, and learn about the role of the brain and the spinal cord. 3 keys to taking control of your pain. One of them is taking ownership. Actually, it doesn't mean to blame yourself for your pain, just knowing that you are in the pain and you are acknowledging that it exists. Number 2 is determining what problems are a result of your pain. What exactly is the issue that we're running into? And reassessing your goal in light of the information that you found out above. Again, some of these things can change, and we're going to talk about all of these through this chapter. So accepting ownership of your pain. If you can take, quote, ownership, then you're starting to have a potential to gain that upper hand on your pain. You are accepting that it is yours, and now you can kind of move forward and start to learn how to cope with the pain that you're having. That's an important step in this whole aspect. You need to cope with some of the feelings that you're having, whether it's sad, angry, anxious. These feelings can disrupt your life, and if you have a disruption in life, that can be an issue. Chronic pain is complex and it has different origins. It doesn't just come from one area, which is why it can be so frustrating. So we just need to make sure that we are understanding the best we can to know why we're frustrated or where this origin is coming from. 2 tools that can assist the patient in taking ownership. The first tool is keeping a pain diary. This is actually the most effective way to track your pain. I have said this to my patients many times, and I'm hoping that you guys will too. When it comes down, what are you having and when are you having it? We all have cell phones now. We can put it right in the notes of our phone. We can track the physical and the unpleasant emotions of the pain. So these physical sensations, some examples: aching, stabbing, burning, pounding, tightness, numbness, tingling. Those are all examples of physical sensations that they could be keeping track of. And also the unpleasant emotions: frustrated, anxiety, anger, sadness, stress. Those are all, again, the unpleasant emotions that come with it. Who will read your diary? Well, doesn't have to be anyone. You can keep it to yourself to give yourself a better idea of when the pain is actually happening, or you can allow your healthcare professional to see it, which can help them determine when or what is going on. And how often should a patient write in their diary? They should be doing it every day for up to 3 months or until the pain is stable. If the pain comes back, then you would have to restart. This is a really good example of a pain diary. I just had my patients write it down. But again, what's the day, time that you're having the pain level, describing the pain, and then your emotional responses to the pain can be helpful. We know that when we become stressed or anxious or unhappy, that can increase our pain. And if we are seeing a correlation, that can help us understand it better. Understanding that your brain is the final judge of what sensory input or any emotional response that's coming out. And that's why everyone's is different. Your brain can become pretty bored. If you think about when you walk into a room and you see a ceiling fan, and your brain goes, okay, that ceiling fan is on, but then your brain sort of shuts it off because it's aware of it and it's done. It becomes pretty bored easily with that constant sounds of pain. As a result, the pain and awareness of pain will vary as well. So we might think of, oh, it's 8 out of 10 all day, every day. Well, that's just our brain kind of saying it. And again, that mood, fatigue, and muscle can all alter that sensation. The second goal the second tool is setting goals. So why do we have to set goals? Well, it brings some order and success and accomplishment into the patient's life. Your goals should be measurable, realistic, behavioral, eye-centered, and desirable. So measurable, how will you know when the goal has been accomplished? Well, that's why it needs to be measurable. A goal should be realistic. Is it possible to achieve, even in pain? A goal should be behavioral. Does it involve specific actions or steps to take? It should be eye-centered. Are you the one engaging in the actions for this to be measured? And it should be desirable. Is it something that you're willing to put forth effort for to meet the goal? I have also done this with my patients, and you can use this sort of for your affiliations and allowing your patients to make sure that these goals that they're setting for themselves on where they want to go are all following under this criteria. Is it for you? Is it something that you need to do? Is it realistic? Those kind of things. Chapter 2, understanding pain. There are various meanings to pain. There's a biological, which is pain is a signal that the body has been harmed. Psychologically, pain is experienced as emotional suffering. Behaviorally, pain alters the way a person moves and acts. Cognitively, pain calls for thinking about its meaning, its cause, and possible remedies. Spiritually, pain may be a reminder of mortality. And culturally, pain may be used to test people's fortitude or to force their submission. Again, if you need a second to rewind, you can rewind and listen to all of those definitions. This is sort of where the book gets a little broad because I already know that you guys know about acute and chronic pain. Acute pain is a time limit between hours and weeks. It's associated with a physical trauma, either tissue irritation or inflammation. This is sort of that warning sign that your body is giving you that something is wrong. Chronic pain is longer than 6 months. There's typically 3 conditions associated with chronic pain. 1 is a painful underlying chronic disease. 2 is damage to the pain nerves. And 3, changes in the brain, spinal cord that control the pain message. Chronic pain can be constant or it can be intermittent. And it typically starts as acute pain and then turns into more of a chronic pain. Some chronic pain conditions that the book lists is nerve pain associated with diabetes, pain after shingles, fibromyalgia, chronic pelvic pain, chronic bladder pain, and post-surgical back pain. And again, I just said this, I got ahead of myself. Pain can be from acute injury, from a disorder or disease that starts as just an acute injury or disorder and turns into more of a chronic condition because it's lasting for a longer amount of time. This chronic pain may cause other symptoms such as depression and isolation. As you've seen, I'm sure, with many of your patients, the longer that they're in pain, the more depressed that they get. Your perception, beliefs, attitude, and mood all can impact the experience that you have with your pain. And understanding that with your patients, they may not be the cheeriest, brightest, happiest patients that come into your clinic. So the feeling of isolation and despair at the loss of physical and social functioning may have become normal. So that not being able to do those social things that you used to do, going to the grocery store, going to Target, going to Starbucks, having a lunch date every Monday with your buddy, those kind of things. And we start to learn how to respond and deal with these feelings. It talks about what are some examples of your coping skills. So I want you to think about that. Just how would you cope? And we'll talk more about this, I believe, tomorrow or in the next chapter that you watch. So the chapter does talk about the processes involved in acute and chronic pain. There is a role of some sensory nerves. You have two types of sensory nerve fibers that carry that majority of the pain, and it's A delta fibers and C fibers. These nerves typically sit kind of just waiting for an event to kind of stimulate into action, and that alarm goes off and those receptors start to move. So your A delta fibers carry the electrical electrical message to the spinal cord pretty quickly at 40 miles per hour. These are that pain that you're going to feel, the tingling pain and the sharp pain. My best example is if you hit your funny bone, or we all know your ulnar nerve. That first sensation that you feel, that sharp tingling pain, that's that A delta fiber that shot up to your brain and came back down very quickly and sent that pain signal. The C fibers carry electrical message to the spinal cord about 3 miles per hour. That's the sensation of achiness, and that spreads slowly. So as soon as you hit your elbow and you feel that sharp and tingling pain, that's that A delta fiber working. And then that sort of spreads out into an achy feeling. That's the C fibers following up right after. The book talks about A beta fibers, which also carries the touch message and pressure message to the spinal cord. So you hit your elbow, you have the A delta fibers working. Then after that, you have the C fibers working in the achiness. Then you take your other hand and you rub that spot that you just hurt. That's the A beta carrying a pressure and touch messages. And that's to kind of help make it feel better. The pain pathway is a two-way street. It goes up to the brain, it comes back down, all while carrying the messages through. And they go, it's amazing how quickly they go. And they have their signals going in, signals going out the whole time. You guys already sort of know this, but some techniques to help with the pain. You have massage, heat or ultrasound, ice, TENS units, and acupuncture. All of these techniques can temporarily alter or decrease the pain message that's going through to the brain from the nerves. So the role of the brain, once the pain signal makes its way to the brain then responds to the strength, repetition, and duration of that message. And that brain gives meaning to the pain message, and from that springs an emotional response. This is that kind of ability to be able to, and learning how your body is coping, how your body responds to pain will help you figure out the best way or route for you. Again, this pain message is sent as an electrical impulse. It's sort of like that relay lace going up and back. Some influences, there's serotonin, noradrenaline, and endorphin. Serotonin is thought to be a contributor to feelings of well-being or happiness. Noradrenaline increases arousal and alertness, and it starts to focus your attention. And endorphins is its body's own pain reliever produced in the brain to help reduce the pain. So all three of those are sort of all working at once. A lot of people suffer from chronic pain. Again, this lasts longer than 6 months. We've already sort of went over this slide. I feel like it's repetitive, but it can be both physical and emotionally draining for your patient. And just those signals are constantly firing throughout the day that it's not only difficult for your body, but it's difficult for your brain as well. Again, this is sort of the same process as an acute pain. Original injury occurs as well as the central nervous system. No cure at the moment for chronic pain. It's just really treatments for the symptoms and the diseases caused by the pain. We just have to figure out what works best. Some diseases associated with it. Myositis is an inflammatory condition of muscles and that causes muscle weakness. But I'm sure that you've already seen most of these in your education so far. Again, some chronic nerve pain can be caused by diabetes, HIV infection. We talked about shingles. Any scar tissue can cause some nerve damage. And then some therapies like chemo and radiation cause nerve damage as well. I actually really enjoy this pain cycle because it gives a really good explanation of what your patient is going through. So you have increased pain, which then causes anxiety. And because you have the anxiety, you have sleep problems. Because you have sleep problems, you're not coping well, all because of your chronic pain seen here in the middle. Then you add some of these other factors in there, worrying about employment, medication problems, family and relationships, financial, other general health issues that you're having, someone who's covering your work, lack of work, doctors and hospital visits and payments to those. All of this can increase your pain, increase your anxiety, and it's just this vicious circle that your patients are dealing with. And you would be surprised at how you can pick apart your patient and find all of these things that's other than just the pain that's causing this increase. So this is sort of more of an acute example of pain, but this can also carry over. If you have cells in cut area, release chemicals that irritate the nerves. The nerves send their signal to the spinal cord. The person feels the pain. Then that body sort of kicks in and the blood vessels in the surrounding tissue constrict, allowing reduction of bleeding. And then the white blood cells and connective tissues start to clean up and repair the site. It's sort of just a walkthrough on how your body responds so quickly in this inflammation and work of pain. But this, again, this is just an acute example. You might have muscle tension. You might be prescribed muscle relaxants. And there are other methods to relax the muscle listed here. I'm not going to read through this slide. You guys can take the time to do that on your own because I trust you. There are some new developments with the brain. The more that we're studying it, the better that we're finding out how the brain works in chronic pain, including with PET scans and fMRI, which is a functional magnetic resonance imaging. This measures the brain activity by detecting changes associated with blood flow in the brain. We're looking at opioids without additional side effects, nerve blocks, electrical stim, all these different things that we're looking at that are helping with chronic pain, also including medical marijuana. So again, your brain is really the final determination on what's happening, and internal and external events can influence how your brain works. How you respond to events in your life can make a difference, and that brain can lower or decrease how loud these pain messages are coming through. And actually, I wish I had read through it before I'd done this video, but I was just at a counseling visit this week, and we had gotten on the topic of acute and chronic pain. And she gave me some material to read over and how different the brain looks in acute pain or chronic pain. In chronic pain, a lot of that is getting the body to go back into this acute pain status to try to decrease it instead of this chronic constant pain. It was fascinating when we were talking about it. So I'm going to read through that and see if I can't get some of that information out to you guys. But other than that, that is it for this slide. If you have questions, please let me know. Thanks. Bye-bye.